Okay, so far in Chapter 20, we've talked about the Neisseria. They're gram-negative cocci, both Neisseria gonorrhoeae and Neisseria meningitidis. Bordetella pertussis, this organism is also gram-negative, and it's the causative agent of whooping cough, or also known as pertussis. Okay, it is if we look at its characteristics, it is a coccobacillus. So the morphology of this organism is somewhere between a round cell, a coccus, and a rod-shaped cell, a bacilli. It's more like you'll see here, in a gram stain, a really, really short rod somewhere in between a cocci and a bacilli. Okay. It's considered non-motile, so no flagella. Like the Neisseria, they are extremely fastidious. So we talked about how Neisseria are difficult to grow in the lab. Same goes with this organism. It's a strict aerobe. All right, so typically this organism, which, by the way, only infects humans, stays in the respiratory tract where it has easy access to oxygen. It's oxidase positive. Remember, it shares that characteristic with the Neisseria. Remember, that's just kind of a diagnostic test that can be done in the lab to test for a particular cytochrome in the electron transport chain. And this test distinguishes, again, this organism, any of the Bordetella, from that huge family of gram-negative rods, the Enterobacteriaceae, or Enterics. Like I just mentioned, at least we're focusing on this particular species, Bordetella pertussis. With this species, humans are the only host. Okay, so there are other Bordetella that can cause animal infections. For example, dogs get what's called kennel cough. But that species that causes kennel cough in dogs doesn't cross the species barrier. So in other words, this particular species is not considered zoonotic. Okay, so humans can be carriers. So that means some of us are harboring this organism and don't really have any symptoms of it, but that means that we have the potential to pass it on to other people. All right, let's start this time with looking at some characteristics of the infection that Bordetella pertussis causes. Again, it's called pertussis, also known as whooping cough. We'll look at the characteristics of that infection and then talk a little bit about, numbers, epidemiology, who gets it, how many people get it, and then into the virulence factors and treatment. All right, so the infection starts out, as all infections do, as some kind of incubation period. Okay, and typically that's going to run about 7 to 10 days from after the host is exposed. They typically breathe in the bacilli. And remember, typically during an incubation period, there are no symptoms. Okay. In pertussis, we like to call the prodromal stage. We have a special name for it called the catarrhal stage. Okay, so again, this just means the prodromal stage. Catarrhal refers to inflammation of mucous membranes, right, in case you're interested. So remember, in any kind of prodromal stage, that means that there are mild symptoms. Okay, so what does that look like for whooping cough? Maybe a little bit of coughing, kind of sneezing, runny nose, kind of mimics, runny nose kind of mimics a cold-like symptoms, okay? And this probably is going to last between 1 and 2 weeks, so pretty long cold. And the interesting thing here in this prodromal stage is when hosts are going to be most infectious. Okay, so I'll just kind of highlight that. That's different than maybe a lot of other infections, but think about it, the host is probably, these symptoms aren't severe enough to keep that person home in bed. They're going to be out doing things that they would normally do, and unfortunately, they're going to be infecting other people. All right, that's followed by a paroxysmal stage. Paroxysmal. It's a tough word to say. A paroxysm is a violent attack. So here, this is another name for what we've more commonly called the illness stage. Symptoms are much worse, typically going to last for in the neighborhood of 2 to 4 weeks. What do those symptoms look like? Lots of mucus production. And we've talked about how mucus production is a good thing. That's part of what we would consider our first line of defense. Traps invaders, and then our cilia help to expel it. You need just the right amount of mucus, right? Too little is bad. Too much is bad as well, because patients have to work really hard to expel that excess mucus, especially because their cilia is impaired, and we'll talk about what causes that. There's a number of toxins that the organism secretes it. Again, the patient has to work really hard to expel that mucus. So we've got a really hard cough, maybe 40 to 50 spells of coughing a day, and oftentimes that's followed by a whoop of the patient sucking the air back in. So if you look on the internet, you can listen for that. It's really kind of heartbreaking to listen to. Like it's usually children or sometimes babies that have that whoop. Adults, when they get pertussis, maybe you don't hear that, but it's just they're so basically needing oxygen that it's a sucking of the air back in. Okay, vomiting sometimes is present, just exhaustion, and possibly even cracked ribs from coughing so hard. Cyanosis basically means your extremities are not getting enough oxygen, even death by pulmonary collapse. Okay, typically that's going to be babies that are most susceptible to succumbing. Okay, so the pictures up here, just some kid coughing. This child has had his capillaries burst in his face because of the hard coughing that he's experienced. You can see the bruising that's caused, and even the bloodshot eyes. All right, if the patient recovers, of course we call this the convalescent stage. Like it says over here, that the coughing is diminishing, in other words, getting better, but it's a pretty long convalescence period here, 3 to 4 weeks. Whooping cough has been called the 100-day cough. Okay, so this is a severe, long infection. So 3+ months sometimes of coughing. Takes a while to clear those toxins from the body. There are in heightened risk even during the convalescent stage of having secondary infections because the cilia has been damaged and epithelial cells lining the respiratory tract have been damaged. So that leaves the patient open to other infections like staph or strep, some kind of pneumonia moving in. So deaths are rare, but it's a very serious infection. All right, so how do you get it? So we'll start with epidemiology, look at some numbers here. Transmission there's no reservoirs. Remember, there's no, animal reservoirs, or it's not, hiding out in the soil or anything like that. It's droplet spread. Okay, so that means, sneezing, coughing, in close contact. All right, so this is not airborne. It's the kind of big droplets that get expelled. And then after the patient inhales, it's going to colonize the trachea, so the upper respiratory tract, and the bronchi. Okay, so again, interferes with that cilia action. All right, looking at some numbers, according to the CDC, we have about 24 million cases worldwide a year, with about 160,000 deaths. In the U.S., if you look at this graph over here, ever since, the mid-'80s here, the cases have been rising. We're not exactly sure what we know of a few things that have contributed to that. The last peak year we had was in 2012, so that's right here, where we had 48,000 cases in the U.S. There's probably was many more than that, because either that goes unreported or undiagnosed. It's not easy to diagnose in adults, but that's been the highest year since in a while, since 1955. Okay, so that's back in here somewhere. And only 20 deaths though, so very few deaths. Again, those are typically in infants. So usually we have somewhere between 10,000 and 40,000 cases in the U.S. Now, before the vaccine was available in the 1940s, if you compare those numbers, there was more like 200,000 children alone sick per year, and more like 9,000 deaths. So again, that would have been before antibiotics. As we'll see, antibiotics don't typically lessen the severity of the disease very much. But again, thank goodness for a vaccine. This is much more manageable disease than what it was in the past. Okay, what are some of the virulence factors that makes this organism so successful? Besides having a capsule, there are a lot of virulence factors that Bordetella pertussis produces to help it establish an infection. We're going to pick out a few that the book mentions and highlight them a little bit. Most of the virulence factors either aid in adhesion or work to limit our innate immunity, especially phagocytosis. So this is an organism that typically doesn't invade our cells, so it's really important that it stays stuck to particular cells. So again, there's a whole list of things. We're just going to mention a few of them. I believe there's 7 or 8 different exotoxins that this organism produces, and the most important one being pertussis toxin. So when we've made mutants of this organism without pertussis toxin, it's not able to establish an infection. So we know pertussis toxin is really important. What are some of the things it does? It helps the organism bind to epithelial cells. So it's an adhesin. It does help block chemotaxis of white blood cells. So like macrophages, it kind of scrambles the signaling that macrophages would use to be able to follow the chemical trail to the site of infection. And we know that it acts to inhibit the motion of our respiratory cilia. All right, there's a lot of overlapping function with Pertussis toxin and adenylate cyclase toxin. This toxin, again, works together with Pertussis toxin in order to basically do all the same thing. It inhibits chemotaxis, also increases mucus production. Okay, so there's actually a homework question about that, how that's a bad thing. Also, again, inhibits killing by phagocytes. Basically, the organism kind of stays stuck to the outside of neutrophils, for example. So it doesn't totally stop phagocytosis, but it makes it a lot more inefficient. Okay, phagocytosis by, again, mostly neutrophils, macrophages, dendritic cells. Okay, one more toxin to mention, tracheal cytotoxin. Tracheal, that's going to stop the cilia movement. Again, like I said, some overlapping function here, certainly. So the patient has to cough quite violently. Okay, there are several different adhesins. Probably the most famous is filamentous hemagglutinin, or FHA. This is a protein in that outer membrane. Remember, it's the gram-negative of the cell wall. Okay, and it's actually, we'll get to the vaccine in a minute, but this is the protein, the main protein that's used in the vaccine. It helps in adhesion to ciliated cells, and recurring theme here, inhibits destruction by phagocytes. Okay, and lastly, I'll mention, of course, endotoxin. All gram-negatives have it in their cell wall. It has a form of endotoxin called lipooligosaccharide instead of lipopolysaccharide, which is more common. And remember, this has a role in inflammation. Not quite as potent as a Neisseria meningitidis, not nearly that potent, but again, this is released primarily when cells die and causes an increase in inflammation. All right, so what can we do about it? How do we treat it? It's actually much better to try and prevent it than treat it. But typically for someone with this kind of infection, okay, it's a bacterial infection, we use antibiotics, oftentimes azithromycin seems to be what they're commonly used, some kind of macrolide. It takes a couple weeks to kill the bacteria, and interestingly enough, there's no drug resistance. So we don't say that very often. I said that for Streptococcus as well. Very little drug resistance to this organism. So I alluded to the fact before that antibiotics really don't do a whole lot. They don't clear the infection very well. The main reason that we give a patient antibiotics is to, let me try to spell that right, is to lessen the chance that the patient will pass it on to someone else. Lessen the chances that the patient will pass it on to someone else. Okay, so remember, antibiotics don't deactivate toxins. The antibiotics don't really shorten recovery time, but they do work as a preventative. If somebody has been exposed, then that's an important step to take sometimes. All right, we do have pretty good vaccine. Like I said, we're ideally going to try to prevent this infection. We talked about the vaccine back when we were talking about vaccines a little bit. In the past, we've used the vaccine called DTP. So that stands for diphtheria, tetanus. These are both inactivated toxins, so it's a toxoid for both of those. Start over again, toxoid. And in the past, we had the Pertussis whole cell that was killed, thrown in there. Okay, so this one is actually no longer used in the US because of the increased inflammation, because of the endotoxin that's included in that vaccine. It worked very well, but there was just a few more side effects with that. Sometimes because this vaccine is a little bit cheaper, sometimes that's used in other countries, less boosters are necessary, so that's a plus as well in certain circumstances. Okay, today we typically use this DTaP today for babies and kids younger than 7. Okay, this is a subunit vaccine that's actually has not only the FHA protein, filamentous hemagglutinin, remember that's an outer membrane protein, also includes inactivated Pertussis toxin. Okay. And sometimes the toxin is inactivated treatment with some kind of glutaraldehyde like formalin or even hydrogen peroxide. Sometimes they will deactivate that toxin through molecular genetic manipulations. Okay. So again, this is the form of the vaccine, again, diphtheria, tetanus, acellular pertussis, that's typically given to young children. Teenagers and adults are given a slightly different vaccine called Tdap, and all the capitalizations and lowercase gets a little bit complicated. But this is the booster, so it's given for teens and adults. It has a little lower dose, okay, so actually more like maybe, well, anybody older than 7 basically is given the Tdap typically. It's a little lower dose. Again, once babies have been immunized, it's more of a booster. And I'll talk more about this, but we found that this is really important. This is the main reason that I like to talk about pertussis a little bit, because especially with this acellular pertussis vaccine, our immunity does wane. And we've been finding once kids are 10 or 12, sometimes they don't have any protection to it anymore. And that's one of the reasons. I have a little short story to tell. In about 2012, right when we had this big spike in pertussis, my son had gone off to a summer camp. And a couple weeks after we got home, we got this email that said, we're sorry to tell you this, but there was someone in your son's cabin that had an active case of pertussis when he was at camp, and somebody else in your son's cabin has also contracted pertussis. So, be looking for these signs and symptoms and all this. And it was just one of those moments where I felt like as a parent I had done something right, because I had made my son get a pertussis vaccine on his previous birthday. And I remember that really clearly because he was really mad that he had to get a shot on his birthday. But I felt like I had done something right. And that's a time when we don't often think about giving our kids vaccinations when they're like 10 or 12 years old. It's really, really especially important for women that are pregnant, usually between 27 and 36 weeks of their pregnancy. It's really important that they get this vaccination, because then they can pass on some IgG antibodies to the fetus, so they have a little bit of protection in the first few months of life. And then if the mother happens to be a carrier, somebody that's around the baby all the time is not going to pass it on to the baby as well. So, if one of those kids at my son's camp had pertussis, had an infant at home, that could have been a really tragic situation. So, really anyone that's around a young baby, the parents, the grandparents should have a pertussis booster shot sometime before the birth of that baby. Okay, and those kids that had it at summer camp, they'd been immunized as babies, and it had just worn off. All right, so hopefully you know a little bit more about pertussis. Next week we'll be going on to some viral infections.